Welcome to my YouTube channel. Today we're going to talk about the diagnosis of a patient who comes in with venous thromboembolism in pregnancy. Kindly make sure you subscribe, it will cost you absolutely nothing. So the first thing that you are going to begin is a person who comes in with venous DVT or PE, you need to have clinical suspicion. And for you to need to have clinical suspicion, you need to know the clinical features. For DVT, a patient will come in with unilateral leg swelling or pain, and the difference between the two limbs, if it's greater than 2 centimeters, then you have a higher suspicion. So as you can see here, it's usually unilateral. Rarely do you have bilateral DVT at rare cases. Most times it's usually unilateral. The next thing is you can have pyrexia and pitting edema in the affected limb, tenderness and prominence of superficial veins in the affected limb, and most commonly in pregnancy, the proximal veins are usually affected. In addition to that, in the left leg is also commonly affected. This is due to the compression effect of the uterus on the left iliac vein, as seen in the picture above. So when the uterus rests here, then it will compress the left iliac vein, causing stasis, which is one of the etiology of deep venous thrombosis. So in terms of pulmonary embolism, so pulmonary embolism, this is when you have a clot in the pulmonary veins in the lungs. And how does this clot occur? Most commonly, the source of this clot is the DVT, that is the deep venous thrombosis, where we have said this is the presence of a clot in one of the deep veins. So when that clot dislodges, then it will travel up to the legs, up to the pelvis, and then it will move to the right ventricle, sorry, right atrium, right ventricle, and then it is pumped into the pulmonary system. There, then it can dislodge. Then there it can be found, or it can be found in the pulmonary artery or block the pulmonary artery. So how will the patient present? The patient will present with sudden onset of dyspnea or shortness of breath, and they'll say it's so hard to breathe sometimes. They may also present with pleuritic chest pain. They may also present with cough, and rare cases they may also present with hemoptysis. This is when you cough out blood. So clinically, if a patient comes in and they have massive PE, then they will present with tachycardia. They'll present with tachypnea, that is fast breathing, pyrexia, raised GVP, and pleural rub or pleural effusion, which is at rare cases. So we go to the next. So the investigations. This is the main part of of what we are talking today. We are going first of all to begin with the. What are you going to begin with? We are going to begin with the baseline test. And what are the baseline tests? With the full blood count. We are going to full blood count. You're going to see the levels of WBC, the levels of RBCs, the levels of platelets. You're also going to do UCs. This is for you to know the kidney functions. So most of the anticoagulants or anticoagulants that you're going to use during treatment of VTE in pregnancy, most are excreted by the kidneys. So you have to take the baseline UECs and also monitor as you initiate therapy. So LFTs, you also, because what is going to metabolize these drugs? The liver. In addition to that, you also do coagulation screening. So in people who are not pregnant or in non-pregnant people, what we we after doing the business, we shall advocate doing the dimers. However, in pregnancy, we shall have a rising of the dimer. So at this time in pregnancy, it is not significant for us to do the dimer. So we don't advocate doing the dimer in people who come in with signs or symptoms of VTE in pregnancy. So what we do for DVT, we do a complexion duplex ultrasound, and this should be a venous compression duplex ultrasound scan. So if it is positive, then you start the patient on anticoagulant. If it is negative and you have a high clinical suspicion, then what is the clinical suspicion? Then the clinical suspicion is those from your history and examination. If it is still high, you still suspect DVT and PE, then what you do, you repeat the venous compression duplex ultrasound 1 week later, whereas maintaining the patient on anticoagulant. So for the sake of PE or in investigations of PE after you have done the baseline test, and also after you have done, because the most common source of a clot in PE is usually DVT. So the clot has to come from somewhere. So you do an ECG and a chest X-ray to rule in or to rule out the differential diagnosis. You also do arterial blood gas, because it's usually it's where in the pulmonary system. And you have seen the previous place you're going to have tachypnea. So how our blood gas analysis? In addition to that, you should do CTPA. CTPA most commonly rather than VTQ. CTPA is the definitive diagnosis. So as I said, CTPA is the definitive diagnosis. However, you can do a VQ scan. However, it is not advertised for women because of increased risk of radiation, which can later cause breast cancer. So take out spoils, you do a venous duplet ultrasound, and for diagnosis of DVT, that is the definitive diagnosis, and for P you do a CTPA.